شكرا لانتظاركم. So we're talking, as I said, about the treatment, the monitoring, the stopping the treatment, the comorbid illnesses, and finally the conclusion. So we all heard over the past couple of years about the evolution of the treatment of rheumatoid arthritis, evolution of the treatment of SLE. What the COVID have initiated for us and what give us an impact about the evolution in the treatment of spondyloarthropathy in general and psoriatic arthritis in particular. With the latest update being on the Saudi FDA, which approved the use of upadacitinib in patients with regard to the psoriatic arthritis in addition to the ankylosing spondylitis. So let me just have, because we don't have a voting question, اللي يحضر لي كتير يعرف أنا I love voting. I like to think, I like to see what do you think. So I would like to have raise of hand. What is the percentage of the biologic use in psoriatic arthritis patient? Please, for those who think 10% ارفعوا يدهم. For those who think 30% ارفعوا يدهم. For those who think 60% ارفعوا يدهم. 90%. None of the above. So according to the Corona Registry, for the percentage of the use of the biological therapy of psoriatic arthritis have been increasing over the past years, from 30 to 60, up to reaching almost 62%. And that was published lately. The latest was in 2018, and it is going to be updated. So with this is a good news, inshallah, yes, because people have been recognizing the disease more. People have been able and having more confidence with regard to arthritis associated with skin psoriasis. There are many guidelines that are available for the treatment of psoriatic arthritis. There's the EULAR, the GRABA, the ACR, as well as the treat to target. But what I'm going to do with you, I'm going to go over systemic approach and what's the most recent updated data that have been presented in the latest UR, in the latest ACR with regard to the treatment of the psoriatic arthritis. So first of all, the polyarthritis, the thing that we're all comfortable with, mashallah, kullakum, excellent rheumatologists who know any patient present with history of psoriasis, family history of skin psoriasis, okay, they will start treatment immediately. But what have been updated is in regard to the methotrexate. Now, patients often find methotrexate to be benefit. ودائما نحن الدكاترة نحب نبدأ لأنه some patients they agreed and actually they do benefit. But actually, do they benefit from it? When they did a web survey with regard to 332 patients, in which 2/3 of them they were biologic treated and 1/3 they were biologic naive. Patients preferred treatment who did not include methotrexate for whatever reason it was, whether it was intolerance, the efficacy, that they have to move on for another treatment, which is quickly. Another paper that have been published as well as have been presented in the EULAR, in the ACR, is the presence and association of the ustekinumab with methotrexate. So they had 4 groups. Methotrexate naive, methotrexate associated. So in other words, the patient was started on methotrexate. And then they further divide them as for those who started the biologic, yes or no. And actually what they found, adding nor continuing methotrexate in psoriatic arthritis patient. We're talking about psoriatic arthritis, please. So adding or continuing methotrexate in patient with psoriatic arthritis did not have any effect on the efficacy, neither the skin or the MSK. So let's move on to enthesitis. What's new about it? We know that enthesitis is one of the entity, Prof. Hani, myself, we presented this maybe 5 years ago. We have been educating the GPs, we have been educating the rheumatologists, telling them that enthesitis is one of the domain which does not respond to biological therapy, to the DMARD agent, specifically methotrexate. And you have to move on immediately to the biological therapy. So do we have anything updated? Because all the biologic therapy, they run in the same line. Anti-TNF, IL-17, IL-23, 23 inhibitors. So this is one of my favorite slides that I made a couple of years ago, and I feel so proud that with regard to the IL-17, I'm not talking about TNF inhibitor. TNF inhibitor have been in the market more than 10 years. we love, we feel comfortable, وبفضل الله عز وجل, we know how to deal with each side effect. I'm talking about the IL-17, both the EXCEED and the SPIRIT trial. If you look at the enthesitis for the EXCEED and the SPIRIT, it's about 60 to 61%. So we have the TNF inhibitor, we have the IL-17, and right now the JAK are coming to the market. Do we have any comparator study, one-to-one? And do we have any objective? I'm not talking about subjective finding in which you ask a patient, did you improve, yes or no? We're talking about objective finding. And indeed, in the ACR, there was an abstract looking at the objective ultrasound finding with regard to improvement of the enthesitis for the IL-17 and the TNF inhibitor. And look at the MACE, which is the Madrid Sonographic Enthesitis Index score to assess the chronic and active enthesial disease. And it states that TNF inhibitor may be better. We don't know, but just keep it in mind. We start right now to recognize enthesitis early. We start right now to treat enthesitis early. So perhaps it doesn't hurt if we start with an older drug. Now let's talk a bit about the JAK inhibitor. So JAK inhibitor, if appropriate. And as I said, the latest that have been approved in Saudi Arabia is the upadacitinib. And for PSA, TOFA have been there in the market since 2017. Alhamdulillah, Pfizer with us. But recently, the UBA have been approved. We don't have any information about the bitter yet. So we knew that with regard to the upadacitinib is superior toward the placebo. The 15 milligram, it's not inferior to the adalimumab. I always like to tell the junior doctors as well as my trainee, when you look right now, احنا دحين طمعنا طموحنا صارت أعلى. ما احنا بس نطالع في arthritis, ما بس نطالع if the tender swollen joint involved. I start to look at the patient-reported outcome. In any study, in any patient, I don't look about improvement of the arthritis anymore. I look about the patient-reported outcome. So there's an improvement of function, pain, fatigue, and the HAC, as well as the radiographic progression, which we know about that. I know that I cannot pass and talk about the JAK inhibitors without presenting one slide that I feel proud to present. Neither Lilly nor Pfizer or even AbbVie have any influence about this slide I'm going to show you. Now, we know over the past months, there have been lots of talk with regard to the risk of DVT-PE as well as the main adverse cardiovascular event. So you're a smart audience. I'm just going to give you some numbers and for you to be able to think. When we talk about the number needed to harm smoking and lung cancer, it's about 5. With regard to the steroid and rheumatoid arthritis, the modest effect, it's about 9.5. For smoking in the mother and the low birth weight is about 16. تقول لك okay, ولدي الحمد لله طيب ما بيغير الصحة والعافية. And she continue to smoke in the second and the third one. Doesn't stop it. The steroid and the main adverse cardiovascular event is about 20. Warfarin, atrial fibrillation, major bleeding 200. ما نخاف, احنا كلنا بنغطي السي تي يو, كلنا internist, بنعطي وارفرين للمرضى. Literally, ما تعطي وارفرين للمريض غير لو المريض كل يوم بيطيح. ساعتها تقول okay, he have a risk of bleeding, ما حاطيله. And then the tofacitinib in cancer, it's about 275. Biological cancer, 375. Tofacitinib, the 10 milligram BID and the MACE is 412. Tofacitinib, 10 milligram BID and the VTE, 763. I'm not advertising for the JAK. I'm putting the number for you. We are smart doctors. We are statisticians. We could decide what to do with our patient. This doesn't mean I'm going to give it in high-risk population. No, there have been studies showing who are the high-risk population. The obesity, morbid obesity, advanced stage, previous cardiovascular disease, both with the previous history of VTE, PE. I'll be reluctant to give JAK inhibitor except if there was no other option and according to the guideline, if the patient were anticoagulated. An integrated analysis that have been presented by Gerald Burmester at the Money ACR published in the Drug Safety, looking at the psoriatic arthritis patient on JAK inhibitor tofacitinib. Actually, the number was about 0.4. And if you compare it to the TNF inhibitor, it's almost comparable. The message I have over here, the studies were done with regard to the risk in RA, but PSA itself, it have a lower risk of DVT as well as PE and MACE in comparison to the RA. So one thing over here, when you look, where is the guselkumab? Where is the Tremfya in the guidelines? Why it's not there? صح ولا لا? Simply because when the guidelines were initiated and updated, it was not approved yet. But I'm not going to go over the Discover trials and the other, because Jazallah khair, yesterday the speaker, he mentioned everything. But the only thing that I have, this wonderful abstract that showed, actually, if you have a patient with chronic anemia, it may improve it in PSA patient. يعني زي ما نقول الأكتمرا في RA, it's helpful in patient with anemia. Perhaps that the guselkumab, it's effective in PSA patient who have anemia. We have all the biologic right now, and they're all in the same line. The message, individualized treatment according to the patient comorbid illness, that's what makes the difference over here. What you will hear a lot about the combination of the biological therapy, and actually go to clinicaltrials.gov. There's the TNF inhibitor and the IL-23, aprilimus, the targeted synthetic TMAR, the JAK1 and the TYK2, and I think that Pfizer, they're going through a study right now. What I mean by this message, الآن كل البيولوجيك, they're going more specific, more cytokine specific. Why? In order to decrease the general side effect. So perhaps by targeting different synthetic DMARD, you could use it in UC patients who have severe skin psoriasis. And please look at the Vegas trial. Look at clinicaltrial.org. It's very promising. So, doctor, okay, I have new biologic, you're telling me to start combination. What about the risk of infection? أنا ما أبغى العملية تنجح ومريض يموت. مريض يموت من infection or sepsis. Absolutely right. And there's an abstract that have been presented about the rate of infection actually or decline. So you're doing a good job. طبعا مريض يجينا نشرح له يجيك التهاب وقف العلاج البيولوجي يخش الناشونال varicella or the national vaccine program بعدين أبدأ العلاج البيولوجي. حتى المرضى الحمد لله although it's taken a lot of time of us. أتذكر واحدة من الشركات جابت patient support program قالت لي يا دكتورة أبغى أكلم المرضى. كلموا المرضى قالوا لهم شكرا ما نحتاجك. ليه؟ الدكتورة already بتشرح لنا. So you're doing a great job. You're explaining to the patient about what to do, and the rate of infection and hospitalization in a Canadian study did prove what you're doing. Comorbidities in PSA. Now, both the EULAR and the GRABA guideline, they recommended to treat the comorbidities in psoriatic arthritis patient because for one simple reason, that's what's killed the patient. Not your arthritis al-ghalbana, okay, that you're treating, it's actually the comorbid illness. Now, the way I explain it في العيادة للمرضى, أقول لهم إنه زمان كان سبحان الله المرضى يموتوا من liver cirrhosis, secondary to hepatitis B. بفضل الله عز وجل the NIH الآن hepatitis B treatment موجود في العالم كله وصار ببلاش الحمد لله عندنا. For you don't see anymore زي زمان مرة كنا طلبة portal hypertension, patient died from liver disease. الآن what kills the patient is actually fatty infiltration of the liver that lead to portal hypertension that lead to liver cancer. والله I have one مريضة في العيادة and she have been having fatty liver almost for 15 years. يا ماما روحي خدي العلاج. يا حبيبتي روحي خدي العلاج. She didn't take it. Actually she presented with liver cancer. وعلى قولة الأونكولوجيست عندها ورمين. واحد زي بيضة الدجاجة والثاني زي بيضة الحمامة. And she went into chemoembolization في جدة والتخصصي والحمد لله أمورها طيبة. So that's what kills our patient. Now, there's a wonderful abstract with regard to the Canadian early arthritis cohort, that is the catch, for the rheumatoid as well as the PSA patient. And actually they used the RDCI. And for those who attended the Young Investigator Day, my students actually with Dr. Sultana, they presented an abstract, an oral abstract about the Saudi population association of RA with RDCI. We did find that the comorbidity index is associated with functional disability, and they comorbidities associated with worse improvement in the disease activity in the first year of treatment. So كل ما تكون أسرع في treatment of comorbidity illness, your patient arthritis will improve. Treat to target. Now, the treat to target with the EULAR and the GRABA guideline, they focused on two, the DAPSA as well as the MDA. And actually, I did this table for you. please feel free to have a screenshot, please, because it shows which domain that each indices cover. We have the MDA and the DAPSA. هذا اللي باكم تركزوا فيه. The C-DAPSA, it's only the absence of inflammatory marker. The review, MDA, there are 7 points, and you should have 5 out of the 7 to consider it as MDA. The DAPSA, the nice thing about it, there are patient pain, patient global, tender joint, tender swollen joint, and the CRP. So, دكتورة, I do it myself with a calculator. كل التريني اللي معايا دكتور إبراهيم، دكتور عبير، الفلو غلطانين بس لازم يتعلموا دي الأشياء وأنا أول واحدة أسويها. So what happened, it does take time. So when the ACR, they come with the rapids, actually 3, and the physical function as well as the overall assessment and the patient overall pain. It's simple. And they found that it is strongly correlated with the other measures applied to the PSA. Why not? We should have an objective measure. Please don't use the DAS28. You're missing about almost 30% of the joint, specifically the DIP. So what's the point of doing the DAS28? Stopping versus tapering in PSA. So they did mention in the GRABA as well as in the ULR, don't stop the treatment. Wallah, I saw many PSA in which 3 biological therapy have been stopped, cycling one on the other, just stopping the medication, the disease flare within 2 months. Please, just caution and taper the medication after the patient have been in sustained remission. Because we know PSA, it's not like the RA. There's a chance of 55 to 100% of flare of the disease after stopping. So the recommendation by both the ULR and the GRABA is to taper medication. And actually, in the ULR, in the poster, actually tour, they did compare discontinuation looking at the DAS versus the tapering. And treat-to-target tapering of the TNF have no negative effect on the disease activity. On the other side, you have a better chance for the patient to be in remission longer. Predictors of response. Now, I cannot pass. دائما, again, هذا موضوع Prof هاني جلسنا دائما ندور عليه. Predictor of response in PSA, in ankylosing spondylitis, in other words, in SPA patient in general. And what I want you to look at في السنين الجاية في كل الكونفرنسز, go look at the flow cytometry result. بفضل الله عز وجل احنا دولة غنية. في عندنا research center. We could have such a test. Such a test will help you and guide you which exact treatment does the patient need. And actually, is it the IL-17? Is it the TNF inhibitor? Is it the JAK? So rather than cycling and switching all the time, you have the chance from the beginning to go to المريض هذا أنسب دواء ليك. So in summary, PSA, it's aggressive disease leading to functional disability showed by all the measures. ما هو شيء جديد, هذا شيء نعرفه من السنين. Methotrexate is stepping backward right now. Patient, they don't like it. They don't tolerate it. It's stepping backward with the new agents. The guideline, whether it was the ULAR, as well as the GRABA, they are domain targeted. Makes sense. Treat to target, please use either the MDA or the DAPSA. Do not, please stop treatment in PSA. Taper it. We do have studies going on about the best regimen for tapering. And finally, manage comorbidity. That's what kills the patient. Thank you so much for your attention.